It's great to have you on the show. Thank you so much for joining me on my podcast.
Oh, it's
Uh,
my pleasure.
yeah, we all I talk about is women's health. That's all I do also at work. So you're right at home. And let's learn about who you are and what you do. And then we can go down our questions and educate our listeners.
Sounds good.
Of course.
Okay, I'm Carolyn Zaumeyer, nurse practitioner from Low TE, Florida, in Fort Lauderdale, Florida. And I inadvertently became a bioidentical hormone expert. When I graduated nurse practitioner school 100 years ago, it seems like, I was fortunate enough to be hired by a very nice OBGYN. And I was curious as to his treatment programs and all that. So I shared a desk with him, and because I knew I just didn't know enough. And I kept reviewing the charts, the whole thing. I saw his little trend for menopausal women was psych referral, psych referral,
Oh,
psych
wow.
referral.
Oh,
Yeah.
wow. Okay.
Yeah. And I didn't know anything about hormones. When I graduated nurse practitioner school, I said, there's two things I will not do. That's right, prescriptions for hormones or thyroid. Now I'm the number one prescriber of MP thyroid in Florida and the number one hormone provider in Florida. You make plans, God laughs, they say. So
Right.
so I went to him with this stack of charts. I collected them and I said, listen, all these ladies can't be nuts. You're sending them to the psychiatrist. He says, they are. They're crying. They're miserable. They're sweaty. They're hot. They hate their husbands. Their relationships are in a mess. They need to get their lives together. And I'm like, okay, can I have those patients? And he says, God bless you. You take the old birds. I'll go deliver babies. And I said, perfect. So
Okay.
then, and this is a new nurse practitioner brain coming out, and I just had to find my way with it. So I started, and this is back in the days of Premarin and Provera.
Yeah.
And so I started helping some patients with it, and I kept getting these fabulous phone calls like, oh my God, you changed my life. You gave me my life back. My husband likes me better. I like me better. And this is just with the estrogen and progesterone or progestin. And it was just like, it kept feeding on me. Okay, this is good. We're helping these women that other people are not helping. And then the old Women's Health Initiative came through in 2002 and blew our hormones out of the water. Over 80% of the American women went off their hormones. Surprised we didn't have a world war or anything like that, because all these women without their hormones, oh my God, I know what I'm like without mine, and it's not good. So I thought we got to find a way to help these ladies safely so that they can feel better and have the second half of their life good,
Yeah.
because traditional medicine just wasn't supplying it. So I had heard about bioidenticals, but I actually had to Google what is a bioidentical hormone. And the bio stands for biology, meaning it's plant-based. Our products are made from wild yams. Identical is referencing the chemical molecular structure, and our product is exactly the same as what our ovaries produce for both testosterone and estradiol. Once I figured out what it was, I knew I wanted to learn more. So I researched out and found 4 of the nation's greats. And I actually went to them throughout the country and studied under them. And I'd come back all excited. Oh my God, this is fabulous. This is a great way to get women feeling better. But they weren't really giving good dosing information. So put a little pearl here and rub it in, or a ribbon. And wait, I got a seed pearl or a jumbo pearl. I got a 1/4-inch ribbon or a 1-inch ribbon. It just wasn't precise enough for my brain, my black and white grid brain. And so finally, on the 4th teaching, I went to Salt Lake City with Dr. Neil Rousier. I went to Orlando with Dr. Sangeeta Patty, fabulous lady. I went to Naples, Florida with Dr. David Rosensweet. And then finally, I went to Texas and studied under Dr. Gary Donovitz, and it all came together. And he really taught me the dosing and the nuances of it, because everybody's different. If I give 3 women that are exact same height, weight, age, the same hormones, totally different reactions. So he helped me really tweak it, fine tune it. I'm very conservative with my dosing in the beginning and then step it up as needed, because little is good. More isn't always better. And then I started my little low TE Florida practice with 0 patients. And I had my gynecology practice. I had a office-based insurance GYM practice. It was huge, but I was working very hard and not making any money. I was supporting the practice, the building, the people, but not myself. And so this new type of practice was helpful because it wasn't covered under insurance. It was cash-based. And so I was able to convert my practice. I met with a local OBGYN. I said, look, you take all the GYN, I'll do the hormones, because I don't know this. And I'm like, I know you don't. Okay, so I got this. So she was feeding my practice a little bit, and all of a sudden it just exploded. And we've had geometrical growth over the years, over and over. This last year or two, I slowed down a little bit. I had to help a brother with cancer go through his fight, and he didn't win. hence
Oh,
the farm, my cowboy hat. This was his farm that he left to us.
okay.
And so then as I turned 65, I thought, I need Fridays off. So that's why I'm still on the farm right now. But anyway, so my practice is very busy. I work usually Monday through Thursday and have pelleted over 23,000 butts. What I use is the hormone pellets, inject them in the upper outer quadrant of the buttock, and have a lot of very satisfied patients.
And what kind of hormones do you use in pellet form? Is it just testosterone or is
No.
it?
Yeah,
Okay.
some providers are doing just a testosterone because they're afraid of the estradiol. Because if you give the patient too much in a pellet of estradiol, it can trigger breakthrough bleeding. So I've learned how to dose it properly, where I can give them a whisper of estradiol to start, see if that takes care of the symptoms. But I include for women that are in menopause, if their FSH is in the postmenopausal range, I'll bring in just a whisper of the estradiol along with the testosterone. And then, of course, if they have a uterus, they get the oral progesterone. That's what goes in the pellet.
Okay. All right. And so take me through, I'm coming into your clinic and I'm having problems sleeping and I can't think and my memory is totally gone and libido is shot. What would you do for me?
I hear that. I hear that time and time again. What we do, what our system is, and it's pretty good. We've got it down pretty good. Is first of all, you can go on our website and fill out your patient packet. And that gives me a lot of good information. And then once you do that, our new patient coordinator will reach out and call you and say, do you have any recent labs? Send them to me, a recent mammogram. We like to have a good mammogram on file to start. If you don't have the labs, we can either get you into my office. We have very good pricing for cash pricing for labs, or we can send you a prescription. You can go to LabCorp Request and hope that your insurance covers it. Once we have the patient packet and the labs, then the games begin. We set up my new patient coordinator, Grizel. She sets up a time on my schedule where I can have a telephone consultation with a patient. I've got most of their information there and I pretty much know what I'm going to do, but I need to talk to them again about the nuances. What are your top 3 symptoms you're trying to get? You know, is it mostly sleep, libido, mood, or is it hot flashes during the day, vaginal dryness? And as those are, some of them are estrogen related and some are progesterone or testosterone related. We bring that all together during the consultation. And then once the consultation's done, I can actually get you on the schedule like the next day or next couple of days and get you treated. And then after the treatment, we have you do your labs again, just the hormones and the thyroid at 6 weeks. And that's when we can tweak it. Because I do dose out conservatively on the first pellet, a lot of times I may need to add a little bit more, but I don't want to give them too much in the beginning because testosterone, if it's too much, especially for an older lady, it can cause this nipple tenderness. And for younger women, if it's too much estradiol, like I said, it can cause a little bit of breakthrough bleeding. It's a little dance that we do, but I've got it. I've been dancing for a while, so we've got it figured out. So that's how we get started. And people will say to me, I was on a podcast the other day with Billy Carson. I don't know if you're familiar with him, but he's internationally renowned. We had over 4,000 views on it, the whole thing. I'm getting inquiries from Australia, Africa, all over the world. And it's like, how are you going to fix me? And I'm like, oh my gosh, what did I do? I opened a can of worms. But I do have people that travel to see me. I have one lady that comes every 3 months from Nigeria.
Wow.
I have one from Romania, 2 from Scotland. One is an actress, a TV actress. I have 2 from Hawaii, throughout the United States, South America, the Bahamas. I have probably over 150 patients from, say, Nassau that fly over, get their pellet, fly home. So if they're motivated to feel good, they'll find a way.
Yeah. And then talk to me more so my audience, because a lot of people don't necessarily know what pellets are. Educate my audience as to what pellets are, how they're inserted, and how they work.
Pellets are just compacted hormone in a tiny little pellet. Picture like a Tic Tac that will be inserted underneath your skin, usually in the upper outer quadrant of your buttock or sometimes into the little love handles. It just needs to go into fat. It only absorbs in fat. If you put it in a glass of water, a year later, you'll go back, it'll be perfectly fine. But if it's in fat, it dissolves. The pellets themselves have been used in this country for well over 80 years. You don't hear about it because plant-based things can't be patented. So Big Pharma hasn't come in, put a fancy name on it, have a lady singing about it because there's no money behind it, a big pharmaceutical company to pay for those commercials. The pellets we use, since it was 1939 is the first studies I can find. I found them in 1979. I was training in surgery in Memphis, Tennessee. And we did a hysterectomy on a woman, closed her up, rolled her over, put the pellets in so that when she woke up, she wouldn't feel so bad. So since they've been used in this country for so many years, we have hundreds of studies showing the safety and also how much healthier it is to age with youthful hormones. When your blood supply passes by, it picks up the little pieces of hormone and gently raises the hormone levels up during the first 4 to 6 weeks. And that's when we test your blood at that 6 week mark, 4 weeks. And then we have our dosing dialed in. And very rarely do I have to tweak it. What's interesting is in my mind, looking at the patient packet, even over the telephone, I'll have it figured out what I want to give that patient. Sometimes it happens like maybe twice a week. They'll walk in, I'm like, oh no. And then I change it just because of their body habits, just how they're built. I know that that's not going to be good. We need to bring it down, or it's not going to be enough. We need to bring it up a level. If I see that they're
Okay.
really muscular and they're working out like maniacs, they're going to burn through it quicker and need a little bit more.
Okay. And you were mentioning where you decided where things need tweaking just by how the patient looks. Like, what are you looking for specifically?
I do that for more of the dosing. 6 week mark, it's more talking on the phone, which symptoms have been resolved, which haven't.
Yeah.
And then looking at the numbers on the labs. And
Okay.
the numbers, I always say the numbers are just numbers. It's most important how you feel.
Yeah.
However, it does give me some guidance. If I see that the testosterone is off the chart, but our libido isn't there, we probably have a high sex hormone binding globulin. So we need to add in some free TE to break that up. So it's like a little puzzle piece. It's fun. I love it. I didn't have access to this, it would be bad because when my hormones wear down, it is not pretty. My mood comes down, my sleep is disruptive, I get snappy, I say things I should never say. I kick out my husband and his dog, and then I realize there's nothing wrong with either one of them. And then I thought, okay, I need a pellet now. And it's amazing the different things that different people notice as the hormones are coming down. I have some women that notice their joint pain comes back with a vengeance. You don't realize how good you're feeling until it starts to wear off.
Yeah.
Then you're like, oh, wow, this was really doing something.
So that can be a real thing where when the hormones are coming down, they're experiencing more symptoms. So what do you recommend so women don't experience that down feeling?
What we do is we put you on this schedule for 3 months after your original pellet. And that usually is a good place to catch you. And a lot of people will stay on that schedule coming in. But what I want you to feel is just, I want it to come down a little bit, but I don't want it to go down to the gutter where we started, because many of the women I start with have no estrogen, no testosterone, no progesterone. I don't want you down there. I want it to go down a little bit so we can bring you back up. So as soon as you start to notice some of the good things going away, that's your perfect time to get a pellet. Give us a call. We'll get you right in.
Okay. Got it. Got it. And then you wrote a book, right?
Yeah, I have one here.
Ah,
The reason I wrote it is because
Yes.
I say all these things that it helps decrease cardiac issues, osteoporosis. It actually helps rebuild bone, arthritis, Alzheimer's, dementia, and even breast cancer. And I needed something to back up what I was saying. I wanted to put the science on paper. So that's what I did in this book, is I explained how this works, how it does help with these different things. Because clinically, I know that it does relay bone, because I've seen it time and time again of women with osteoporosis with it correcting without taking any of those evil medications that can give you a necrotic jaw or bone cancer. It's, oh, good, you have strong bones, but you have bone cancer. No, this naturally will help rebuild that bone. And I have some women coming in just for that, because they have osteoporosis, their mother had it, and they want to do their best not to age with osteoporosis. Right. So I've seen it over the years, doing like a DEXA scan every 2 years, see it correcting. I have one that had like severe osteoporosis. She's now in osteopenia. And so she was crying. She was so excited. She says, I just knew I was going to have a horrible old age like my mother, and I didn't want to do that. And we're rocking it.
Yeah. I think there's a whole generation of women, that my mom included, that just got skipped over.
Oh, yeah.
When it comes to this. And I often wonder what could have been. Who knows if she would have accepted hormone treatment at that time or not, right?
I tell you, my mother was on hormones, thanks to Carolyn, for most of her life. Then she had a hysterectomy. Then I started correcting her with Premarin and Provera, and then Prempro. And she's 91, and she's clear in the head. Alzheimer's, dementia, none. She's singing in the choir, learning new music every week, driving her golf cart around, just adopted another dog. Her skin is nice and thick and healthy like ours. It's spotted and a little bit wrinkly, but it's not that thin, friable skin. See, in some elderly women, it looks like you could tear it. And that's from not aging with estrogen. If you age with estrogen, you should have healthy skin. Your same thing's going on downstairs as what's going on up here. So
Right.
if it's crispy up here, it's crispy down there, and that's not good. We don't want a crunchy vagina. We want it good. I remember with my mother years ago when I first started doing this, we were sitting at a restaurant on the
Yeah.
beach and I was pointing out to her the ladies that had the benefit of estrogen as they age versus the other ones. It was so clear.
Yeah. You need estrogen to support the collagen production.
Absolutely. And a lot of things.
Even if you're taking collagen, if you don't have the estrogen, it's not necessarily going to help you.
There's two basic different sciences of hormones. And there's the synthetic hormones that we grew up with, the Premarin, Provera, birth control. That was all synthetic hormones. Bioidentical is the plant-based ones that we use. And they're like apples and oranges. What was bad about this one is good about this one. Like the synthetic progestin, it caused deep vein thrombosis, heart attack, stroke, breast cancer, Alzheimer's. And ours is supporting all that stuff, preventing all that stuff. So, and that's what really is, I think that may be one of your questions. What is the biggest myth out there or problem that people are hearing that just isn't true? And what bothers me the most is, and they do it on the national news all the time, they don't say whether the study they're reporting on is on synthetic or bioidentical. And most of the reporting they're doing now is they're regurgitating stuff that, from the breakdown of the Women's Health Initiative in 2002.
Yeah.
But I had one on, I have her name down. She kept referring to progestin, the evil progestins that cause all these things, as progesterone.
No.
If I was just a viewer watching that, I would have stopped by progesterone. And that's not good because if you have estrogen on board, you have to have your progesterone to balance it out so you don't get endometrial cancer.
Exactly.
So she did a real disservice to women by not saying the right hormone. So I have a little letter transcribed I'm going to have to send to her.
Yeah. When did this happen?
It was about 2 or 3 weeks ago.
Okay.
And what I've been seeing, like even on Good Morning America, maybe 2 months ago, all of a sudden there was this headline that hormones are now safe for menopausal women. And I'm like, oh, finally, they got it. Okay. They go back and everything was great till the end where they said, yes, if you start before menopause, it's good for you, but not after. And you should only really stay on it for 6 years. Right. Really? You want to, how old are you going to live to? About 100. Okay. So at 50, you don't get to feel good for another 50 years.
Yeah.
So it's just so wrong because there's nothing wrong with it. It's not unsafe to have bioidentical hormones.
Yeah.
It's exactly the same as what your ovaries produce. So how could that be bad?
Yeah.
So it just, that's the thing. They just don't identify bioidentical versus synthetic. And it's so very different.
I feel bad for women in general because I think there's obviously more of an awareness. It's being covered on social media more. There are more doctors coming out, healthcare practitioners who are coming out and talking about all of this. And it's come to the limelight. I think patients don't necessarily know what's right or wrong. And there are times even, and I can't think of, it was something that I saw, and I can't think of what it was. It was just recently. That's my brain fog kicking in, but whatever it was, I was like, that's not right. Whatever she's saying, that's not correct. And so then I have to think about my patients or just women in general who are caught in the crossfires of all of this. Now it's like information that may not be totally accurate, right?
A patient told me the other day, she says, we're doing the work for our daughters.
Yeah.
We're going through all this. We're exploring it. We're learning it so that we can share it with our daughters. Because as she was walking in the room, she was hanging up, telling a coworker that I'm here where you're going to be next week. I'm getting my pellet, because she's sharing the good news because she doesn't want everybody to feel bad. And it's good that women are talking about it, but there's so much misinformation, even on Dr. Google. It's just like, you can't believe everything you read. You have to really see the source, see the study, dissect it, find out what they're studying is that in the Women's Health Initiative in 2002, that the estrogen arm, the women without a uterus that didn't have to take the progestin, did great. Less breast cancer, Alzheimer's, a whole bit. It's a lot of information to try to sort out on your own. And what I do every day is take those phone calls. I've been researching this. And I'm like, yeah, I have too, for about 40 years. What'd you learn?
Yeah. Here's the thing, though. I was in residency when the WHI came out, and we had something called Journal Club. I was at NYU. And so we had this Journal Club where we would dissect the article or research that came out, a lot of these things we already knew at that time. At least my fellow residents, we had already in our journal club pointed out the flaws of that study.
Yes. And that's fabulous. Yeah. But that didn't hit the front page of the newspaper.
No.
What hit the front page of the newspaper was hormones kill.
Yeah.
Don't get on hormones. Oh my gosh, your breasts are going to fall off. No.
Yeah.
And it's just not true.
Yeah. Yeah. I still remember being in that journal club and going through it and then always feeling confused. Okay, we've already dissected this and certain things are not as scary as they seem, but yet this is the way it's being portrayed. And yeah, and that's why I always feel like generation of women got a raw deal out of all of this.
I applaud you and your journal club because you guys are progressive. Because in my book, it lays out that like only 5 to 6% of the medical schools even address menopause and hormones. So you guys were ahead of it. Good job.
As someone who sees patients who seek you out, can anyone see you? It sounds like anyone who wants to see you can see you.
Absolutely.
Okay.
I treat both male and female. And some of my patients are even young patients. Like I've got one young man, he's 22, and he's got this very rare condition that just is making his body just really not good, losing his bowels, the whole thing. And he just needed a little bit of happiness. And so we got him a little bit of testosterone cream, and it was life-changing for him. So I do see people of all ages. My oldest patient, I believe, is 92 and is still playing tennis. So I have all age groups, both male and female. About 30% of my practice is male, and they get great results, and they just keep coming back. I've got like a 94% return rate for the second pellet, meaning it meant that much to the patient to go through it, lay a little bit of money down, and get their pellets.
For someone who's looking, maybe they want to be in the same state as their healthcare practitioner, I often find that some of the patients who seek me out for these kind of things, they feel frustrated that they're not able to necessarily have that conversation because I serve as their primary care physician. They're not even entirely sure that I'm the doctor to prescribe them medications or even have that discussion. Yeah. I'll give you an example. One time I went through the whole song and dance with them. It took 20 or 30 minutes and the patient was like, okay, so then who's going to prescribe the medication for me? It's like, what do you think this is?
I know. I go through it too.
Do you? Okay.
Yeah. You're not alone on that. And that can be a little frustrating because it's kind of like discounting what you, it's like, I've been researching this and it can put you over the edge sometimes, but you just got to take a breath and understand that and what I have to remind my staff is that the women coming in a lot of times can be a little bit sharp, a little bit not nice.
Yeah.
And I just tell them, remember, they don't have hormones. It's not their fault. They don't have the nice hormones. I'll give it to them. When they leave, they'll be all happy. And they are. And they leave and then they're nice from then on. But sometimes they come in just, menopause, just not good.
You're allowed to say that, but no man can ever say that. Okay.
That's right. It's saying, are you on your period?
Well, no, they can't say that either. What I was leading to with my question is if you were to guide my listeners as to what to look for in someone who can guide them, what should they look for in a practitioner who can guide them through this transition?
It's very hard because what happened is many practitioners have added hormones onto their practice as basically just a moneymaker. They don't know it. They don't understand it. They can't handle the nuances. What do you do? Oh my gosh, you have breakthrough bleeding. How do you handle that? And so there's even I know of a psychiatrist and a neurosurgeon that are pelleting people. So what do they know about gynecology and handling breakthrough bleeding? I'd look for somebody that's been in the field for a while. And it's hard to say, I can't tell you a website to go to find the perfect practitioner because people can pop up on these training and research sites that have done one pellet. So it's okay. I don't want to be number two. So I guess asking what their history is, or a lot of times it's all on their website. Did they start doing it yesterday? If there's no picture of the practitioner, if there's no history about the practitioner, a bio or anything like that, I'd probably turn around because you want to be totally transparent. I am who I am. I'm a nurse practitioner, not a doctor, but I have been studying hormones for most of my life and I got this.
Yeah. When patients ask you, that study that came out in 2002, it showed that I have a higher risk of breast cancer. and heart disease and blood clots and what have you. How do you educate them? Like, how do you go through the
Well,
steps with them?
very rarely do people ask about it. They just know that there was bad press. A while ago,
Yeah.
it came out that hormones are bad. But what I try to explain to them is what we've talked about it, that it was the evil progestin and not the progesterone.
Yeah.
If they had done that study, and plus it was a bad study because it was all the same delivery system, oral, which first passed through the liver, not good. All the exact same dose, no matter how big or small the women were. So that's what I try to tell them is it was a bad study, poorly done with the wrong hormones. And what we use is totally different. It's like apples and oranges. Ours is good. That was not so good. The interesting thing is even a lot of pharmacists don't know the difference between progestin versus progesterone, to the point that I spoke at one of our local pharmacology meetings with a pharmacist in, I think it was 3 counties. We had over 250 pharmacists there. And I thought, oh my gosh, they're going to roast me. They're going to get going on a molecular stuff and all this. No, they were totally silent because I was explaining the 3 different progestins versus the progesterone, the bad part about the progesterone, the good part of the progesterone. And they'll even put in the wrong little flyer with the pills. So you'll get your progesterone and it'll say progestin and they'll call me, oh my God, I'm going to have a blood clot. I don't know. They just don't know.
Yeah. Wow. That still happens where, the wrong information.
Oh, yeah.
What other services does your clinics support or provide?
What we do is 95% hormones.
Okay.
It's really my focus. And that's probably what you would want to look for in a provider, is one that does a lot of it or enough of it to be knowledgeable in it. And I do a little bit of vaginal rejuvenation. It's a laser treatment for the vagina. It helps with mild urinary incontinence, helps snug up the vagina, and helps reset the pH balance. So I do that just 1 or 2 a month. It's not a big deal. Okay. I've got a fabulous nurse working for me that's doing fabulous Botox, and she'll still be doing fillers, but I don't do that. So you don't want me doing it. I'll do my own, but nobody else. And that's probably, we do some weight loss. Yeah. And we play with different weight loss programs. You've probably heard of the HCG diet, and a lot of people poo-poo it. It's been around forever, but it's very safe and it's very quick. 10 to 20 pounds in 3 weeks. And I've written a book on it. So we have it all down. We have people that really like that because they can knock it down. We help them stabilize, lock it in so they don't just gain it right back. Teach them how to eat for the future.
The HCG diet isn't really...
Nobody's doing it. It's a secret. What happened is a lot of places were doing it, and then the laws changed. The big pharma got the compounding pharmacies shut down on making the HCG. So everybody but me stopped doing it. But I researched out how I could buy it from big pharma. It's more expensive, but I've got the real stuff. And I've just carried on, and it's so good. And I've never had anybody have a health issue with it. I spoke to Dr. Oz about it, and he says there's not a white paper out there that'll take away the appetite. I've done it enough. I know it takes away the appetite. You get to where you don't even want to eat anything. There's appetite.
An injection or?
Yeah. It's a tiny little diabetic needle injection into the abdomen. You do it every morning. The first week is incredible. Most people lose 5 to 10 pounds. So that really encourages you to stick with it because it's not fun. You're not eating the fun foods and drinking the fun drinks that everybody else is.
And then like with the GLP-1s, right? Is it something that you have to maintain?
No, that's the good part. I don't know what the future holds. If everybody is going to go off and gain it all right back, what good do we do? And how's that pancreas? Treating the pancreas, a perfect pancreas with diabetic medicine. So a lot of questions for the future on that one.
The pharma companies are making a lot of money off of it now.
Absolutely.
One of the biggest complaints that I have for women in midlife, right, is sleep issues. And sleep, obviously, it can be a big component, and it can get affected when you're having these hormonal imbalances during menopause and perimenopause. So how do you address, besides the hormone replacement, how do you address the sleep issues with your patients?
If they're not corrected, usually with our hormone therapy, most people will say they get a much more delicious sleep.
Okay.
And if they don't, then we have to dive a little bit deeper, you know, and there's so many components that go into it. Their environment, their exercise, their eating, drinking, alcohol, the whole thing.
Yeah.
So we have to do a deeper dive. But then there's also sleep studies because a lot of people have sleep apnea that they don't even know about. You can just be like a little purr, like a cat, and still have sleep apnea. A sleep study is a good thing.
I encourage a lot of my patients when I can't necessarily figure out what's driving the insomnia. I'm like, listen, there's so many insurances that cover it while you're at home. right? Instead of having to go to the sleep center, let's just get one done. And oftentimes it's bang, bang, it's right there. All right, let's see. We went through a lot of these questions, sleep. And you did talk about the crunchy vagina. I'm wondering if I should use that as a title.
Crunchy, crispy, snap, crackle, pop. You can have a little party with it.
With hormone replacement, even with women who are having discomfort with intercourse, and if the HRT is often not enough, how do you address that? Is it the vaginal rejuvenation? Are you using topical agents as well? How do you help them through that?
Yeah, it can be a combo, but usually I can get it taken care of with the hormones.
Yeah.
Because estrogen is the moisture hormone.
Right.
Also dry eye, joint pain, dry
Right.
vagina, skin. So usually I can dose that up. It just depends on their age. When I may have to take it adding on a patch instead of more of the pellet, or the vaginal suppositories or creams. And then if it's like they're never getting wet, like the secretory glands aren't working, then the vaginal rejuvenation works, because it's basically like getting a laser on your face. It's knocking off that top layer, waking those cells up.
Got it.
So a lot of times they have much better moisture.
Okay. All right. And with the hormone replacement that you're using, do you find that often addresses the midlife bulge, the abdominal girth?
It's a tough one.
Yeah. Yeah.
That's a tough one. I have more people losing weight than gaining weight.
Okay.
But that abdomen is a tough bear. And when I feel bad, because I have these girls, they'd sit in my office and they grab their middle and they're like, what the hell is this? You used to have a flat stomach. What happened?
Yeah.
And studies show women gain 10 pounds with or without hormones during menopause. And apparently that's where it's landed. After menopause, our bodies start processing food differently.
Yeah.
When we were in our teens, we could eat fruit for a day and lose 10 pounds. Now, that doesn't work. But it seems like anything white that you eat, sugar, flour, rice, potatoes, bagels, chips, crackers, all that's what wants to land in the abdomen and stay there. Oh, but I love bread. Yeah, it loves you too. It doesn't want to leave you. It's going to hang around there for a while unless you change your behaviors. So that's the first thing, because I had one girl that went totally without any of that for like just 2 weeks and lost 9 pounds. And it was just with that. She said every time she opened the fridge, she'd hear my voice. And I'm like, oh my God, this beautiful voice. Croaking at you. Don't do that. So, yeah, I think that's the one, because if you go like on a straight keto, mostly meat, maybe some green vegetables, it usually will go away. But that's hard to maintain.
It is.
With life.
It's not sustainable.
And then I never want to say that alcohol could be a problem, because I don't want to tell somebody to stop drinking. But I had this one lady that wanted to lose her little belly for a dress to wear to a wedding. And I knew she was a wine drinker. And I said, okay, let's stop the wine, just the wine for 2 weeks. Boom, her stomach went fine. We went to the wedding. She came back. She says, I'm happier with my little belly and my wine. She made the life choice. And
exactly.
If you try these different little things, you may notice a nice difference.
Yeah. Yeah. So I'm not a big drinker, but I've noticed that the wine for a lot of my patients can be a trigger. Caffeine can also be a thing, causing some hormonal stuff. It can be tricky. Let's play some rapid fire questions. So
speed dating.
Speed dating. Have you ever been speed dating? I hate it. Tell us about a myth about menopause that you wish that would totally disappear.
That hormonal therapies cause cancer.
Okay. One lab value that is totally overinterpreted, and these are two questions. One, that people, doctors, patients, nurses, should watch more closely. So these are two separate questions.
For menopausal women or premenopausal women?
Let's say both.
Okay. Progesterone in the postmenopausal woman really doesn't give me anything to work with. So I honestly don't even test it unless they ask for it.
Okay.
Because I know to protect their vagina, their uterus from the buildup of the lining of the uterus at 200 milligrams is the best dose. And so I know that, and I'm not going to vary from it unless they have a reaction to it where they feel hungover in the morning or groggy or just not good, depressed, whatever. Then I'll switch them over to a rapid dissolve tablet.
Okay.
But progesterone overrated. Watch more closely. I tell you, I have been finding more pre-diabetics. The hemoglobin A1C. I tell you, I added that into my panel a couple of years ago. I found 5 diabetics or true diabetics that had no clue.
Yeah.
And you could end up dead. So that's important. So I think hemoglobin A1C is a great tool. And I do watch that. I have some patients that I give them some guidance and they're able to correct it. My father his hemoglobin A1C went high years ago when I got him going and no sugar, nothing made from white flour, at least 30 to 40 minutes of fast walking 6 days out of 7. He died at 86 and he wasn't diabetic. So the reason I think it's so important is we can catch it when it's pre-diabetes, face it back, where we just wait. And like my brother, I have him on metformin and his doctor wanted to take him off. And I said, why did she want to take you off? She said that you don't have diabetes. I said, so we want to wait till you have diabetes to put you on metformin? You know, you're pre-diabetic. There's a reason you're on it.
Yeah.
And he always calls me, what do I do now? I said, ignore it. You just keep taking your metformin. And no harm in it.
Yeah, and I'm always arguing, who says that 5.7 is actually prediabetes? Why isn't it 5.6? And why is 6.5 diabetes? Why isn't it 6.4? Who made these, you know, these cutoffs, right? You can have a sugar like several times in a row of 126 and still have an A1C of 6.4. So that doesn't mean you don't have diabetes.
Yeah.
Really ridiculous. So yeah, and then I have patients that are like, oh, my A1C is now 5.5. I'm not a diabetic anymore. I'm like, nope, you're a diabetic.
If you don't watch it, they'll go creeping right back up there.
I'm like, you're on Manjaro, you're on metformin. We have you on a low glycemic diet, like when you're exercising. So we're doing the things to treat your diabetes, and that's why your A1C is lowered. But no, you've crossed the threshold. You had an A1C of 9.7 before. So so there's no going back. There's just controlling it and treating it. For me, I think in terms of labs, I feel like a more detailed for either premenopausal or postmenopausal or menopausal women, like a detailed cholesterol panel, including a lipoprotein A.
Yeah.
I just feel we really need to do our due diligence to screen for heart disease as much as possible.
Yeah. They say that more women die of heart disease than breast cancer or any cancer.
That's right.
And what I try to encourage, you're doing primary care, you can handle it, but I don't do cardiology or anything like that. But when I have a woman over 50, I'm like, do you have a cardiologist? Yeah. And they're like, no, I don't need one. Yeah, you do. You need to at least go in, do your baseline.
Exactly.
You know, they find blockages. They find all kinds of wonderful things. So it's at least get established with one so you have one you can call when you're in the emergency room.
Exactly. For me, this happened more during COVID when there was a lack of doctors in general and cardiologists were stuck in the ICU. And so there was a serious lack of cardiologists, pulmonologists, infectious disease doctors. So at that time, about 5 years ago, I was like, okay, I'm going to be the cardiologist. Yeah. I'm going to do all these screenings that I would refer to my cardiology specialist. So I continue to do that now. So I'll have that conversation with them. And then only if I pick up something substantial will I send them out.
Gotcha. Your patients are lucky to have you.
Oh, thank you.
Not all practitioners do that. And for me, I don't do the cholesterol screening because number one, I don't feel like the literature is there for women taking a statin. Yeah. I haven't seen one study done on women and the potential side effects. And then if you can get a calcium score done to find out if you have any of the soft plaques, that can give you some guidance as well. And I compared the reference ranges and the total cholesterol stayed the same. But from my understanding, this is what the word is, that Big Pharma got in cahoots with the labs and got all those other ones moved down. So everybody qualifies for a statin. Then if you don't write for the statin, shame on you. If they have a cardiac event, then, oh boy. So it's like a little pickle. You like that?
Yeah. You have to wonder, right? How much of that is being driven. I always wonder. I do. But that being said, the screening is important. And I guess calcium scores and again, only when I find something substantial do I refer out. But I do think part of a good primary care plan is, especially for women, to address that. And especially with menopause, that increases our risks for heart disease, among them.
Unless we get your hormones optimized and that brings it down.
That's right.
Very cardioprotective.
Carolyn, it's been a pleasure. If we were to look for you in terms of your website, your book, any social media handles, where would we find you?
My website is LOW, T as in Tom, E as in Edward, Florida spelled out .com. And everything is there. If you want to get your hands on this little book, probably shouldn't tell you this, but you can get it for free off my website. You just put in your little information and we mail it out to you. I've been mailing them all over the world since I did that thing with Billy Carson.
All
Thank you
right.
for having me.